please come to order. Just for my colleagues. There's people with other committees that have to get out like pronto. And so I thought that Senator Sanders and I would do our opening statements, and then we'll allow people to fill in. But as soon as we have enough people to do the vote, we're going to vote, and then let people get to their other committees. So we'll go ahead and start with, shall we say, less than a full House, trusting that the House will come full. First, let me begin by thanking Dr. Menarez, if she's watching this, for coming before the committee last month. The United States needs a CDC director who makes decisions rooted in science, a leader who will reform the agency and work to restore public trust in health institutions. With decades of proven experience as a public health official, Dr. Menarez is ready to take on this challenge. She is committed to improving transparency at the CDC and properly communicating health guidance to the American people. Dr. Menarez will work to modernize our data health systems to improve public health coordination and response while protecting Americans' sensitive health information. This is especially crucial as the nations combat re-emerging public health threats like measles, which has taken 3 lives in the United States this year. One that's not included but is tragic. A Canadian woman who was pregnant got exposed to measles and lost her child, and hospitalized many more due to misinformation regarding the measles vaccine. I support Dr. Menarez's nomination. I urge colleagues to do the same. With that, I recognize Senator Sanders.
Thank you, Mr. Chairman. I will be voting against President Trump's nominee to be the next director of CDC, Dr. Menarez. The mission of the CDC is, quote, to protect America from health, safety, and security threats, both foreign and in the United States, end quote. As the CDC states on its website, quote, whether diseases start at home or abroad are chronic or acute, curable or preventable, human error or deliberate attack, CDC fights disease and supports communities and citizens to do the same, end quote. Unacceptably, President Trump and Secretary Kennedy are working overtime to undermine the vital mission of the CDC and are jeopardizing the health, safety, and well-being of millions of people, both at home and abroad in the process. And unfortunately, Dr. Menarez, who has served as Trump's acting CDC director, has done nothing to stand in the way. Under her watch, the Trump administration has illegally delayed or canceled $11 billion in public health funding to fight infectious disease and to prepare for the next pandemic, purged important public health data from its website that scientists need to respond to disease outbreaks, and fired scientists who focused on worker safety, the health of mothers and children, birth defects and disabilities, smoking cessation, and HIV prevention. Further, Dr. Menarez stood by while Secretary Kennedy spread misinformation about vaccines. The chairman mentioned the serious problem that we have in vaccines. He is right, and that is exactly one of the reasons why we should reject this nominee. Today, the United States is reporting the highest number of measles cases in 33 years. In my view, we need a CDC director who will defend science, protect public health, and repudiate Secretary Kennedy's dangerous conspiracy theories about safe and effective vaccines that have saved, over the years, millions of lives. Unfortunately, after reviewing her record, I do not believe that Dr. Menarez is that person. I would encourage my colleagues to oppose this nomination. Thank you.
So again, for the folks here, we started, for those who just arrived, we started early because so many people have committee hearings and they've got to get to. Now, on the Republican side, we need to have all of us stay until all of us have voted yes. And I'm told that people are like showing up before Senator Collins has to leave. Okay, so, but I suggest that we start voting now, and then when the people like Hawley walks in, because I'm told he's arriving shortly, we'll get his yes, and we don't have to go through the whole list. We don't have to go through the whole list. Is that okay with everybody? Yep. Okay, sounds good. The clerk should call the roll.
Okay. Senator Paul?
Aye.
Senator Collins?
Aye.
Senator Murkowski? Senator Mullen? Senator Marshall?
Aye.
Senator Scott?
Aye.
Senator Hawley?
Aye.
Senator Tuberville?
Aye.
Senator Banks? Senator Houston? Senator Moody? Senator Sanders?
No.
Senator Murray?
No by proxy?
Senator Baldwin? Senator Murphy? Senator Kane? Senator Hassan? Senator Hickenlooper? Senator Markey? Senator Kim? Senator Blunt Rochester? Senator Alsobrooks? Chairman Cassidy?
Well, like Banks came in and then I think he was ghosting me, you know what I'm saying? Like, he walked in and then gone. Senator Murkowski texted she'll be here in 1 minute. Keep the timer. And just for everybody, our regularly scheduled committee hearing will begin at 9. And then, so we'll adjourn after Senator Murray makes her, after Lisa arrives and Senator Murray will make a comment, then we'll adjourn until 9.
Yeah.
So 10, I'm sorry, 10. So, okay. 10. So who has the most,
Mr. Chairman, if I could change my proxy vote to an in-person vote of aye.
Without objection.
Or no, no. Good.
We object to the rechange, so.
So Senator Murray votes no.
Thank you.
When was the last time LSU won it?
But baseball, if you haven't noticed. We're doing pretty well baseball.
So you don't. No comments?
Crazy.
You refuse to comment on this?
I do, actually.
Senator Murkowski? Senator Murkowski? Oh, vote aye? Yep. Okay. I have 12 ayes, 11 nays.
The ayes have it. The motion is agreed to. The nomination will be favorably reported to the Senate. The Help Committee will be adjourned after Senator Murray makes her statement.
Thank you, Mr. Chairman. I appreciate the opportunity to just make a comment because I think it's really important as we consider a CDC nominee today, we talk about the real elephant in the room because we could actually have the best CDC director in the world and it wouldn't change the fact that we have a person leading HHS who is an anti-vaccine conspiracy theorist and a committee that I fear is failing to do its bipartisan public oversight of public health disasters. Measles cases are at a record 33-year high. They've not been this high since before we eliminated the disease in 2000. And now we're over at 1,200 cases. That is really, we believe, also an undercount. But instead of pounding the pavement to encourage people to get vaccinated, the single most effective protection against measles, as you know, RFK Jr. has been firing every single member of the CDC Vaccine Advisory Panel, and he loaded it up with his favorite vaccine skeptics so they can pursue debunked conspiracies. And I am concerned because this committee, it feels like, has all but abandoned its serious oversight of this crisis. We haven't had a hearing on the record-breaking number of measles outbreaks or a hearing on how the CDC vaccine panel is now stacked with people who are actually not vetted. And all the previous board members, every single one of them was removed with no credible explanation. So I really believe we need public oversight. And I really do hope that Dr. Menares will defy my expectations. I hope she will stand up for science and put public health first. But again, I have hoped that for others, and here we are today. So I just want to express my disappointment and my real feeling that this committee should have oversight and do hearings before it's too late to do anything at all. And I would just say my door's open to everyone. I think that we do need to work together and try and repair some of the harm that this anti-vaccine conspiracy theorists are doing to our country right now, and I hope you take that into consideration.
So heard.
Thank you.
Adjourned. The Senate Committee on Health, Education, Labor, and Pensions will please come to order. I'm a doctor. I've seen how technology is improving Americans' health. More accurate diagnoses, fewer procedures. When was the last time anyone had to do an exploratory surgery? Which people below a certain age don't know what that is. Before you had CT scans, you would just open up a belly and look around, causing all sorts of problems, causing future surgeries. Now, the federal government has invested billions in technology, and a good example is the electronic health record, and now AI is being implemented in healthcare settings. With these new technologies, however, we must address the threats of cyber attacks and loss of control of sensitive information. There were more than 730 cyber breaches last year, affecting over 270 million Americans, including the attack on Change Healthcare, the largest healthcare cybersecurity incident in history. This attack exposed the data of over 190 million people, leading to significant delays in care and in electronic prescribing. Further delays in claims processing resulted in billions of delayed provider payments, bringing many health practices to the verge of bankruptcy. To ensure patients fully benefit from the advancements in health technology and are not harmed, Congress must work with healthcare entities to improve resiliency against cyber attacks. I introduced legislation with Senators Maggie Hassan, John Cornyn, and Mark Warner last year to address these challenges, and I look forward to working with President Trump and my colleagues to advance this legislation through Congress and get it signed into law. Beyond cyber attacks that threaten Americans' health, we must also harness the power of big aggregate data and artificial intelligence while preventing the misuse of patient data. The Health Insurance Portability and Accountability Act, HIPAA, has been effective at protecting clinical information for decades, but the law has not kept pace with new technology or with innovative tools like wearable devices and apps that are now an essential aspect of healthcare. Many of these tools are directly marketed for health purposes, yet consumers are unaware that this data is not protected by HIPAA. Rural providers are also unable to best use the data collected via electronic health records to deliver personalized care, given the significant barriers to aggregating and analyzing de-identified clinical data or other health information. Currently, Americans have few legal protections and control over their health information captured by devices. Sensitive data can be collected, batched, and sold by data brokers to any buyer on the market, including geopolitical adversaries that can abuse this data for nefarious reasons. Last Congress, I published a report outlining proposals to empower patients to control how their data is used. This includes modernizing HIPAA, as well as safeguarding health data not covered by HIPAA. I'm also working on efforts to better leverage AI in healthcare and to assist rural providers with finding value in the population-level data that is available. I look forward to discussing these proposals with our panelists today. Thanks to all of our witnesses for being here to share your ideas on the above topics. With that, I recognize Senator Sanders.
Thank you, Mr. Chairman. There is no question but that cybersecurity and protecting the privacy of Americans' healthcare records are important issues that need to be dealt with. But, Mr. Chairman, let me be very clear. That is not the issue that is right now on the minds of the American people. What people are worried about is the catastrophic impact that the reconciliation bill that was passed last week will have on the health and well-being of the American people. And that is the issue I'm going to be focusing on today. That legislation, passed by one vote here in the Senate, will be making the largest cut to Medicaid in American history to pay for the largest tax break for billionaires in American history. At a time when, as I think all Americans know, our current healthcare system is broken, it is dysfunctional, it is cruel. 85 million today are uninsured or underinsured. This bill will make a horrible situation even worse. This legislation will cut Medicaid and the Affordable Care Act by more than $1.1 trillion. The nonpartisan CBO has estimated that this bill, along with the expiration of the enhanced premium tax credits of the ACA, will cause 17 million people to lose their health insurance. All right? 85 million today, uninsured or underinsured. Only country, major country on earth not to guarantee health care to all. 17 million more will be uninsured. Researchers at the Yale School of Public Health and healthcare economists at the University of Pennsylvania have found that these healthcare policies, and I almost hesitate to say these things because people are not going to believe it, because it is too cruel, too unimaginable. But they are estimating that this bill will cause over 50,000 people in our country to die unnecessarily every year. And that's what happens when you can't get to a doctor. And I'm delighted that one of the lead researchers of this report, Dr. Allison Galvani, is here with us today to talk more about that study. Mr. Chairman, it is not rocket science. You're a doctor, you know this. If people don't have access to health care, if they can't get to a doctor when they need to, people will suffer and tens of thousands will die. It happens today, it will only get worse. Make no mistake about it, this bill is a death sentence for working class and low-income Americans. Further, as a result of this bill, it is estimated that more than 300 rural hospitals are now at risk of closing down altogether or substantially reducing their services. That is not my estimate. That is what the Center for Health Services Research at the University of North Carolina recently estimated. And we are already beginning to see the devastating impact this bill will have on rural America. The Curtis Medical Center in southwest Nebraska has already announced that it will be shutting down because it cannot withstand the cuts to Medicaid contained in this bill. And it's not just rural hospitals that are now in crisis as a result of this legislation. According to a recent study from the American Healthcare Association, as a result of this bill, 27% of nursing homes, I can tell you that in Vermont, nursing homes are in desperate shape today, and I suspect that's true all over the country. They are estimating that 27% of nursing homes have indicated that they will be forced to close their doors, and 58% will have to reduce staff. And it's not just nursing homes. Healthcare researchers at the Millikan Institute of Public Health at George Washington University have found that this bill will be a disaster for community health centers, something that many of us feel very strongly about, providing primary care to 32 million low-income and working-class Americans. They have estimated, Millikan Institute, that as a result of the passage of this bill, over 40% of community health center sites will shut down. Today, there are over 15,000 community health center clinics throughout America. This could result in the shutting down of some 9,000 of them. And it's not just community health centers, not just nursing homes, not just individuals. This legislation will substantially increase the uninsured rate in every state in this country. As a result of this bill, the uninsured rate in my own state of Vermont, which has one of the lowest uninsured rates in the country, will go from 3.3 to 6% uninsured. In Louisiana, the chairman's state, the uninsured rate will go from 6.7 to 12.4%. In Florida, it will go from 10.4 to 18.8%. In Texas, second largest state in this country, uninsured rate will go up to 20% in the United States, in the richest country in the history of the world. And on and on. So, Mr. Chairman, this is an issue that needs to be explained to the American people, and I look forward to discussing it with all of our panelists. Thank you.
I will take advantage of explaining some of the things in there which are not true, but this hearing is about cybersecurity. And I hope our witnesses will limit their remarks to that. If not, we will suffer through them otherwise.
This hearing is about health care in America, and I hope the witnesses will tell us the truth about what's going on today.
And so, again, to our hearing about cybersecurity, which is an important issue within healthcare of America, I'm here for the whole event, so I'll defer first to my down dais, Dr. Marshall. Oh, testimony, I'm sorry. I got distracted. Mr. Garcia, let me introduce you. I apologize. I'm distracted by the distraction. We are joined today by Greg Garcia, the Executive Director of the Healthcare and Public Health Sector Coordinating Council. You say HSCC or HISIC? HSCC is the government-recognized critical infrastructure advisory council of more than 460 healthcare stakeholders, partnering with government to identify and mitigate cyber threats to health data and research, systems, manufacturing, and patient care. Mr. Garcia was previously appointed by President George W. Bush as the nation's first Assistant Secretary for Cybersecurity and Communications for the U.S. Department of Homeland Security. I look forward to hearing from you today, sir. Thank you for joining.
Thank you, Mr. Chairman. Senator Sanders, thanks for inviting me to testify. You did a good introduction of the Health Sector Coordinating Council, the Cybersecurity Working Group. I'm the executive director of that. As one of 17 designated critical infrastructure councils, we partner with government under a national policy framework to identify and mitigate cyber threats to the healthcare system. So our sector faces a number of critical threats and disruptions that involve health data and research, administrative, financial, and operational systems, medical product manufacturing, and most importantly, patient care. So this is where we are today. Because of cyber and ransomware attacks on the health system, hospitals turn patients away, unable to care for them because systems are down and patient records are unavailable. This impact is especially dire for small, rural, resource-constrained health providers. Insurance companies lose millions of health records to hackers who use them for identity theft and reimbursement fraud. Pharmaceutical and medtech manufacturing can grind to a halt when computer-operated factories are disabled or corrupted. Cyber vulnerabilities in third parties that support the healthcare industry can result in cyber disruptions that threaten patient care and health systems, and corrupted or lost population health data impede the ability of public health agencies to track infectious disease and other health concerns. Against this backdrop of persistent threats and attacks, the Cyber Working Group has led dozens of work streams, sometimes jointly with Department of Health and Human Services, to build an arsenal of defenses in the form of cybersecurity best practices. They're all developed on the imperative that cyber safety is patient safety. Over the past 7 years, we have so far issued 26 of those resources and 15 policy advisories. They are all available for free on our website at healthsectorcouncil.org. But we're not doing this alone, nor should we. Until recently, we have been collaborating with government under an advisory committee framework called CPAC. This allows the government to meet with us and all critical infrastructure councils in a protected environment to share sensitive information and consider strategic policy options. But the CPAC framework was canceled earlier this year for reasons that are puzzling to us. This leaves government out of the discussions that can help us collectively counter the adversary. Now, we are the private sector owners and operators of the health system, and it is our responsibility to ensure its security and resiliency. But the government should be at the table with us, and they should be able to promote to the broader community our effective cybersecurity resources that we have spent so much time and energy on, and that we can hold ourselves accountable to. We hope that CPAC, or some revised version of it, will be reinstated stat. This applies equally to our recommendation that the Congress reauthorize the Cybersecurity Information Sharing Act of 2015, which expires in September. This law supports industry's ability to voluntarily share sensitive information, threat and vulnerability information with the government without fear of regulatory jeopardy or public disclosure. The second thing I want to say, Mr. Chairman, refers to a proposed update to the HIPAA security rule published in January, which you referred to. By most accounts, the proposed rule is cumbersome, vague, costly, fairly unrealistic, and questionable for actually improving cybersecurity, which is what we are focused on. In April, we formally advised the administration to suspend further consideration of the proposed rule and organize a series of consultations with leaders in the health sector to negotiate a modernized policy for healthcare cybersecurity. There is precedent in policy for this process. We've not yet received a response from the administration to this proposal, but we stand ready to work with them when and if they are organized for this challenge. This would allow us to negotiate effective cybersecurity rules, some mandatory, others flexible, that we will be held accountable to. We can start with the many best practices that we have already published by the sector for the sector. And not only for the healthcare providers, but for the whole interconnected healthcare ecosystem, particularly third-party IT and software service providers that are not regulated. Cyber vulnerabilities lurking within their technology and services are implicated in 50% of data breaches and cyber attacks on healthcare. They need to be held to a higher standard when connecting to patient data or administrative and operational health systems. We have numerous other recommendations we can discuss that address our 5-year cybersecurity strategic plan published in February of last year. I request that it be entered into the record. If together we can make progress toward the strategic plan, we can upgrade our healthcare cybersecurity diagnosis from critical condition to stable condition by 2029. Mr. Chairman, that concludes my oral statement, and I look forward to answering the committee's questions.
And no objection to entering that which you wish to have entered into the record. We're also joined today by Renee Quashi, the Vice President for Digital Health at the Consumer Technology Association, CTA. Mr. Quashi provides guidance on key regulatory and policy issues related to AI, health technology products, services, software, and apps. Prior to CTA, Mr. Quashi practiced law and the use of technology in healthcare. Thank you, sir, for joining us.
Thank you, Mr. Chairman. Thank you, Senator Sanders and the committee. My name is Renee Quashi. I serve as Vice President of Digital Health at the Consumer Technology Association, or CTA. We are the largest tech trade association in North America. We represent more than 1,200 member companies, from iconic global brands to early-stage startups and small businesses. We are responsible for 18 million American jobs. 80% of CTA's companies, again, are small businesses and startups. We produce CES, the world's most powerful tech trade event, and lead national efforts on technology policy, market research, standards development across emerging technologies. CTA member companies are pioneering advances across a spectrum, from AI-powered continuous glucose monitors to remote patient monitoring, to the first FDA-cleared obstructive sleep apnea risk detection feature for consumer wearables. These advancements are not only transforming how patients access care, but also putting them in control by delivering personalized insights and screening for signs of chronic disease before a costly adverse event. This is more important than ever, as patients across the country face incredible barriers, as Senator Sanders mentioned, to accessing care, driven by provider shortages, among other things. But none of this innovation is going to matter much if people don't trust that their health data is protected. Health data is among the most personal and sensitive information we generate. Patients will not adopt tools they do not trust, and providers will not recommend platforms that they believe put patients at risk. Companies cannot innovate at scale if they're navigating conflicting, outdated, or unclear laws. Yet, our current privacy framework is outdated and incomplete. Many consumer-facing digital manufacturers and deployers are not considered covered entities under HIPAA, and often are not subject to business associate agreements with HIPAA-covered entities. That is why CTA has taken a leadership role in advancing both privacy and security in health innovation. Back in 2015, CTA released the Guiding Principles for the Privacy of Personal Health Data. It's a voluntary framework designed to help companies, especially those that operate outside HIPAA's scope, to implement responsible data practices. The principles were developed and subsequently updated twice by a working group that included technology companies, telehealth and remote patient monitoring companies, healthcare providers, commercial payers, and other innovators. While CTA believes guidelines and industry standards play an important role, we recognize the need for a comprehensive, preemptive federal data law that protects consumers and promotes innovation without incentivizing frivolous lawsuits and creating a patchwork of state privacy laws. On that point, currently 20 states have privacy laws. For businesses, especially small businesses and startups, complying with that many laws stifles innovation and creates unnecessary barriers to entry. Navigating conflicting or inconsistent requirements increases legal risk, drives up operational costs, and makes it harder to build uniform products and services that meet consumer expectation. For consumers, it makes little sense why one person located in one state might have differing rights than another in a different state, even if they're using the same product. Ultimately, we need a uniform, risk-based, and innovation-friendly federal privacy law to achieve this balance. The absence of a comprehensive federal framework has led to an increasingly complex and fragmented patchwork of state rules, creating consumer confusion and placing undue compliance burden on small and medium-sized businesses. A well-structured federal framework without a private right of action would enhance consumer protection while fostering regulatory certainty that spurs American innovation. CTA stands ready to work with the committee to advance the use of digital health tools, including supporting comprehensive federal data privacy legislation. That ends my statement. Thank you very much.
Thank you, sir. And Senator Husted will introduce Ms. Stevenson.
Thank you, Mr. Chairman. We are joined today by Linda Stevenson, who is the Chief Information Officer at Fisher Titus, an acute care hospital in Norwalk, Ohio, near the north coast of our great state. Ms. Fisher has over 35 years in health information technology expertise, supporting patient care and clinical functions. Throughout her career, she has led teams at Cleveland area hospitals, including the Cleveland Clinic, Metro Health, Southwest General, and most recently for the Cerner Corporation. Linda received her MBA from Cleveland State University, and I look forward to hearing from her today, and I want to thank you for joining us, Ms. Stevenson.
Thank you, Senator Husted. Chairman Cassidy, Ranking Member Sanders, and members of the committee. As said, Fisher Titus is a rural and independent hospital in Ohio, serving over 70,000 residents. I'm also a board member of an organization called CHIME, the College of Health Information Management Executives. Today, I will focus my remarks on the daily challenges that my facility and other rural hospitals face as we experience growing cybersecurity attacks against us and our patients. Thankfully, I do believe there are ways to address these challenges. Hospitals undertake and devote significant resources to securing our systems. However, cybersecurity is costly, and recruiting and retaining qualified IT and cybersecurity professionals remains a challenge for small, rural, and under-resourced hospitals. The shift to remote work has only exacerbated that cause, and we are competing for talent with much larger, better-resourced organizations across the country. Most rural hospitals cannot afford a full-time cybersecurity leader of any kind. At my own hospital, I play the role of CIO and CISO. When hospitals face budget constraints due to stagnant payment rates, they are often forced to reprioritize spending, directing limited resources towards immediate operational needs and away from long-term spending, such as cybersecurity. The challenge is even more acute for rural hospitals, the majority of which are operating at a loss. 50% of rural healthcare operated at a loss in 2024. That was up from 43% the year before. Without the funds and access to cybersecurity workforce, rural hospitals will continue to struggle. A catastrophic cyber attack can bring a hospital down for weeks or even months. If we're forced to divert patients, the 3 nearest hospitals are about an hour away. And community like ours can have a devastating and potentially life-threatening impact on patient care. With regards to regulatory burden, the impact of complying with multiple overlapping and burdensome healthcare mandates can be debilitating for a rural healthcare organization. We must meet the same standards as all of the larger organizations, but lack the staff and the infrastructure to do that efficiently. Any efforts to reduce or streamline regulatory burdens and improve operational efficiency would be appreciated. Rural hospitals like Fisher Titus are actively making improvements to improve our cybersecurity posture, but we cannot do it alone. Ongoing support for federal tools is needed. We follow the NIST cybersecurity framework, 405D tools, and all the materials used by CISA. We are also a member of the Health ISAC, which shares cybersecurity threat intelligence. However, the cost of membership is out of reach for many rural hospitals. While we're doing our best to establish a robust cybersecurity program, healthcare providers are too often punished rather than being treated as victims. Every day, we are on the front lines, fending off increasingly complex and relentless intrusion attempts. We're up against well-funded criminals that have greater resources than most of our U.S. hospitals. We must shift away from punitive approaches. These only worsen the burden and divert resources from patient care Instead, we need to support policies that empower healthcare providers to strengthen their cybersecurity defenses. Providers also wrestle with significant vulnerabilities brought on by third-party partners. Managing the security of hundreds of external partners is resource-intensive for all hospitals, but especially for rural healthcare providers. It would be incredibly helpful if we had an approved list of vendor products that have already been vetted and that meet a baseline set of standards of privacy and security. This would bring efficiency to the marketplace and help under-resourced providers purchase third-party services with greater confidence. Finally, the legal and operational responsibility for ensuring HIPAA compliance falls too heavily on provider organizations. While business associates are contractually obligated to protect patient data, too many fall short, placing additional strain on already stretched rural hospitals. In closing, I'd like to thank the committee for giving me this opportunity to testify on these important issues. With more knowledge and understanding of the realities of healthcare in our rural communities, we can work together to improve care for all. And I do look forward to your questions.
Senator Sanders.
Thank you, Mr. Chairman. I'd like to introduce Robert Weissman, co-president of Public Citizen. Mr. Weissman has led Public Citizen, a national nonprofit consumer advocacy organization, since 2009. He is a leading national expert on corporate and government accountability. Rob, thanks very much for being with us.
Thank you, Chair Cassidy and Senator Sanders and members of the committee. Cybersecurity is a serious problem threatening the healthcare delivery system in America, and it's growing worse due to technological changes and underinvestment by large corporations. I wanted to focus quickly on a series of external factors that are poised to supercharge the problem of cybersecurity risk. The first is the problem of corporate concentration, which means we have large data sets that are very vulnerable. In the case of Change Healthcare, that led to a breach that impeded or interfered with the privacy of 1/3 of American patients. Second, cuts in reorganization, firings, office closures, and drifts at the Department of Health and Human Services is imperiling the safety of data at HHS and undermining the agency's ability to enforce standards against private actors. Third, DOJ has gained access to at least 19 data sets inside of HHS, is combining them perhaps also with external databases in ways that are unknown, for purposes that are unknown, with protections that are uncertain. Fourth, the Medicaid cuts that are included in the reconciliation bill will, as we just heard, put pressure on rural and other institutions who do not have excess capacity to deal with cybersecurity. Fifth, the rise of wearables, chatbots, and AI-assisted medical devices is creating huge data troves of private information, personal private health information, not subjected to HIPAA or any real meaningful privacy protections whatsoever. And last, the big tech companies are seeking to gain immunity from lawsuits or regulatory standards related to privacy and data security and other measures. This Senate just voted down by 99-1 a proposal to give them that protection, and hopefully that'll be the last we hear of that proposal, but I don't think it will be. However, as significant a challenge as cybersecurity is, this hearing's objective of securing the future of healthcare is far more seriously threatened by the reconciliation bill that the Congress just passed. As Senator Sanders indicated, and as CBO has stated, that legislation will cost healthcare coverage for 17 million Americans. We know what that means. It means people will be sicker than they need to be. It means they will skip preventative services that they should obtain. It means they will not get treatment when they need it. It means when they do go to get treatment, they will pay more than they should. And it means, ultimately, that many will die needlessly. As Professor Galvani will explain, 50,000, not once, but every year, excess deaths in America as a result of this bill. It will also devastate the healthcare infrastructure itself. Rural hospitals will close. Community health centers will close. There will be ripple effects throughout the healthcare sector that we're going to live with for a long, long time, and we did not need to do. The ostensible reason for this was to save, in quotes, about $1 trillion to be used to pay for tax cuts for the super rich. Those aren't real savings because they just actually are offloading costs from society onto private individuals, the poor and the vulnerable, will pay in reduced health care or out-of-pocket costs. However, there are actual genuine savings available in the healthcare system at scale, available to Congress if it chooses to obtain them. If we dealt with the problem of excess drug pricing, we could save conservatively $200 billion a year by cracking down on Big Pharma's price gouging and monopolistic practices. At a 40% cut, the country would be paying the same as the VA, but still more than other countries. We could save $100 billion by ending privatized Medicare. Those savings would actually save us money by increasing efficiency, ending waste and abuse, and expanding coverage and quality of care. We could have even larger savings by taking on the problem of administrative waste in the healthcare system, which is vastly higher in the United States than it is in competitor countries. If we move to a Medicare for all system, we could conservatively save $700 billion a year in administrative overhead. $700 billion a year, that's $7 trillion the way we count for budget reconciliation. $7 trillion. And we would do so not just by saving money, but by expanding care. That is the way forward for this country, not to cut back and punish the poor and vulnerable, but by deliver on the nation's promises, expand healthcare, crack down on corporate abuses, and deliver the quality and affordable care that all of us need, deserve, and have a right to. Thank you for this right to testify.
Okay. Ms. Galvani, I hope you're, I'm sorry.
I'd like to introduce Dr. Allison Galvani, who's a professor at the Yale School of Public Health. Dr. Galvani is the founding director of Yale Center for Infectious Disease Modeling and Analysis. She conducts health economic modeling on a range of public health challenges, including infectious diseases and policy changes from insurance losses. Dr. Galvani, thanks so much for being with us.
Thank you for the invitation to testify about our research. In collaboration with the University of Pennsylvania, we recently evaluated the public health ramifications of the reconciliation bill. According to the Congressional Budget Office, as been mentioned, 17 million people are poised to lose their health insurance. We found that as a result, over 51,000 Americans will die unnecessarily every year. Beyond mortality, we estimated the repercussions for the treatment of chronic conditions. We project that with the loss of health care, over 130,000 cases of diabetes will go untreated, along with 101,000 cases of substance use disorders, 165,000 cases of hypertension, and 201,000 cases of mental illness. As they lose access to care, these people will face diminished quality of life and what would have been avoidable suffering. These figures don't even account for how cuts to nutrition programs will further erode health. Medicaid requirements are ostensibly presented as cost-saving measures. In practice, they do the opposite. In both New Hampshire and Arkansas, the implementation of reporting requirements led to thousands of eligible people losing coverage in just the first few months, with no improvements in unemployment rates. These states also incurred millions in administrative overhead since the regulations cost more to operate than they saved. Both programs were then suspended early. It's also critical to recognize that the loss of health care is economically counterproductive in myriad other ways. When people lose coverage, they're more likely to delay care until conditions become severe and expensive, often ending in ER visits that strain hospitals. More families will face crushing medical debt and a reduced capacity to remain in the workforce due to unmanaged illness. Meanwhile, healthcare providers, especially in rural areas disproportionately reliant on Medicaid, will be left absorbing uncompensated care, fueling closures, and reducing access for entire communities. There is a way that Congress could improve cost efficiency, but it is not by cutting health care. It is by expanding health care to all Americans through a single-payer system, such as the Medicare for All Act proposed by Ranking Member Sanders. We can look to many other countries that save money and lives through universal health care. By contrast, we spend more than any other country. The return on our investment is paltry. Despite spending more, we don't even rank in the top 40 for life expectancy among other public health measures. In our analyses, we found that a single-payer system would save over $500 billion annually. That is more than $500 billion saved through administrative streamlining, negotiating prices, and preventative care, among other aspects. Most importantly, universal health care would save more than 68,000 lives annually, as opposed to this bill causing 51,000 deaths. Taken together, these findings underscore a simple but urgent point. If we avoid the destructive rollbacks and instead expand health care, we could save 120,000 lives every year while spending less as a nation. Cybersecurity is particularly a concern in our fragmented system, since patient data is spread across hundreds of insurers, providers, vendors, and billers, each a potential weak link. I'm also concerned that patient data is monetized in our for-profit system and can be used for debt collection. By enacting policies that unify and expand healthcare, this committee has the opportunity to galvanize a new era of American well-being, security, and prosperity. Thank you again, and I'd be pleased to answer any questions you may have.
Senator Husted.
Thank you, Mr. Chairman. I want to just start by saying that I understand Medicaid is a state-federal partnership. For the last 24 years, I've worked in state government in funding nursing homes and hospitals and providing for care in our state. I have a letter, Mr. Chairman, I would like to submit for the record from rural hospitals in Ohio talking about how the most recently passed legislation is so helpful to them.
Without objection.
It will increase funding for rural hospitals in Ohio by 24%. Previously, they were receiving 91% of the Medicare rate after the passage of the bill, and by subsequent actions by our partners at the state level, they will be receiving 115% of the Medicare rate. That does not mention the fact that we also have a $50 billion rural hospital fund that's available, even though rural hospitals only received $10 billion in funding total, according to CMS last year. So I just want to submit that information and make sure we have those facts available. Now, Ms. Stevenson, we've talked a little bit briefly about cybersecurity breaches and the challenges that are faced. I know that we talked a little bit about rural hospitals and the fact that really it's, in some cases, a talent issue. You know, can you find the people with the cybersecurity skills to be able to accomplish the defense that's necessary? What suggestions do you have on how we can help? Because I know some of the things that we've done in Ohio have been establishing cybersecurity as a high school program at our career centers and in partnership with business. So are you working with any of those collaborations at the local level with our educational institutions to build the cyber talent that you need to help serve you?
Thank you for that question. Yes, absolutely. One of the things we focus on in Norwalk is connection to our local colleges, high schools, and even to two-year colleges to engage them at the intern level so they get exposure to healthcare and get experience in the real world, whether that be IT or cybersecurity. We very much agree with that approach and want to take a thought back to when Meaningful Use came out years ago, and we put out there grants and programs to provide more education on meaningful use in informatics back then, and is that an opportunity for us to try that again with cybersecurity, given the new focus going forward, to encourage young people to go into that path? But yes, we absolutely are partnering with every education opportunity that we can.
And you had also mentioned the need in your remarks to move away from punitive policies that punish providers when they have a hack or a cybersecurity breach, and then a vetted directory of third-party vendors would make it easier for rural hospitals to enhance cybersecurity. Could you expound on that a little bit?
Absolutely. One of the challenges we have as we partner with, whether it's a vendor or an external consultant or any organization that we might work with, is ensuring that they have as much protection around the data that we do, because the patient's information flows through all those places. The burden right now is on each of us to vet that. So I need to submit system assessments to a particular vendor, ensure that they complete the information and they have a robust program before I can even contract with them to do the work. And that is very burdensome for us to have to do that, and every other healthcare organization in the area have to do the same thing. So if there was a standard set of privacy and security rules or regulations that they all needed to follow, we could have more trust in that and remove the burden from everyone of doing duplicate work.
And where should that be? Where should that home be for that list? Who should be responsible for it?
That is a great question, and I don't think that I have an exact proposal for that. I think we have some amazing cybersecurity groups in the works right now, whether that's Health ISAC or CISA or any of those organizations. I think that would be a recommendation of the senators, Congress.
Well, it's interesting. I mean, you know of the resources that we created in our state with the cyber range, and we literally have at the National Guard a cyber militia. We think of militia as people carrying weapons. Well, this is a group of cyber militia that's literally trained to help respond in times of crisis. I think it's probably underreported, underutilized, but those are kind of resources that I think we can all help and create. Thank you,
Absolutely.
Mr. Chairman.
Chair recognizes Senator Sanders.
Thank you, Mr. Chairman. Dr. Galvani, you and your colleagues at Yale and the University of Pennsylvania have estimated that 51,000 people will die each year as a result of this reconciliation bill. How did you come up with those estimates?
Our estimates are based on the congressional budget calculation that 17 million people are poised to lose health care. We can then compare, from empirical studies, the rates of mortality, age-stratified mortality, for people who are insured versus uninsured. There's about a 40% higher rate of mortality for those people, and that's how we generated that number. In addition, the University of Pennsylvania calculated the impacts of changes to nursing home safety procedures and the removal of pharmaceutical subsidies for seniors and Medicare.
A moment, I'm sorry he left. Senator Husted thought that this legislation would be a positive for rural hospitals, quoted a statement from some folks in Ohio. The University of North Carolina has estimated that this legislation will cause over 335 rural hospitals in America to shut down or substantially reduce the services they provide. Mr. Weissman, what is your sense about how this legislation will impact rural hospitals throughout the country?
Although I'm from Ohio, I don't know what that reference was, but I think the best evidence is it will be devastating for rural hospitals. And the $50 billion was about a third of what's going to be lost overall for rural hospitals from the bill. I think what you just said is really important. A significant number will close. Others that stay open will massively scale back the services they offer. And as we know, what that means for people in rural America is that they're going to not get access to care. Often the rural hospital is not just one of many hospitals, it's the one that they can go to, and the choice is to not go at all. There are also economic linchpins and community centers. We're going to see really the de-atomization of rural America worse as a result of this Medicaid cutback.
Okay. Ms. Stevenson, I know that you're not the CEO of that your hospital. Do you have any thoughts about the impact of the reconciliation bill on rural hospitals?
Certainly, we are spending a lot of time in doing evaluation of that right now. Because it's so recent, I don't have any details. However, I can tell you that any cuts for organizations, if that were to arise, depending on how that's appropriated throughout the states, it means fewer dollars to invest in, whether that's for patient care or it's for cybersecurity. So more to come, but we are certainly watching it closely.
Thank you. Dr. Galvani and Mr. Weissman talked a little bit about rural hospitals. We talked about the impact on primarily low-income and working-class people who will lose their health care. According to a recent survey, 27% of nursing homes in America, and not just an issue, Mr. Chairman, we don't talk about enough. I could tell you that in Vermont, nursing homes are struggling. But this bill will make that situation even worse. There are estimates that up to 27% of nursing homes indicating that they will be forced to shut down, and 58% are reducing their staff as a result of the bill. Anybody want to comment on the impact of this legislation on nursing homes? Rob?
Well, as you know, Medicaid is how most people pay for nursing homes. Medicaid also provides reimbursement to people for Medicare costs who are living in nursing homes. That's going to be restricted. I know this from a personal experience. Many of us do. Nursing homes provide crucial assistance for people in their later years. If they can't go, which is what it means, there's incredible suffering that's going to take place and intolerable burdens on the families as a result.
Okay, well, thank you very much.
Well, among the half-truths being promulgated, the nursing homes are carved out of this legislation, so I'm not sure how they're going to be affected. That said, let's go with some real.
Oh, Mr. Chairman.
No, sorry, I got the gavel.
on.
No, I got the gavel, Bernie. This is about cybersecurity. Thank you all for those who actually talked about cybersecurity. I really appreciate that. Okay, Ms. Stevenson says, Mr. Garcia, Mr. Quashi, that she needs a good housekeeping seal of approval on vendors. That seems like something you two could do. Is there nothing out there that would say to someone like Ms. Stevenson, you don't have to do an independent survey? No, we give you a good housekeeping seal? And keep your answers tight, please. Got a lot of questions.
Senator, yes, that is something we've been thinking about in the Sector Coordinating Council, is how do we evaluate all of those third-party service providers for their cybersecurity expertise? And it is a difficult question. There's thousands of vendors. There is a
Okay, cut to the chase.
a federal example like FedRAMP. If you're going to sell to the government like cloud services, you have to meet these cybersecurity conditions in order to sell to us. We could have the same framework.
We being the federal government or we being you?
We being the industry.
Yeah, why aren't you?
It's a difficult issue, and we're going to need help doing that. It's
Help from whom?
And we will have opposition from a lot of the technology and service.
Yeah, but I
providers
mean,
who
the
don't
people who
wanna
are being served, Ms. Stevenson, she needs it.
Yeah.
I mean, I think that we need to actually put the person who's, the entity which is actually providing the care first, and not the people who are just trying to sell a product.
That's exactly what we have advocated, is that those that are serving any critical infrastructure, healthcare,
Okay, got it.
financial
Mr.
services,
Quashi.
they need to be held to a higher standard.
CTA has developed a cyber trust mark, as a matter of fact, doing just that. Now, its application to healthcare is in question, but it's something we can certainly look at, and I can certainly provide information for that, but that's exactly what the cyber trust mark does.
And so, wait, that's what you actually do now, or that's what you hope to do in the future?
No, the cyber trust mark is alive and well. Yes, that's what we do.
That's what you do. Ms. Stevenson, are you not finding that helpful?
That's not something we have exposure. Sorry, that's not something we've had exposure to at this point.
Okay. Next, Ms. Stevenson, you're really interesting because Mr. Weissman spoke about how he doesn't want. I think you spoke in favor of allowing states to come up with their own privacy laws, and you spoke kind of like we have a patchwork. And you're the one who said, wait a second, if I've got this overlapping with that, it becomes incredibly difficult for a rule. Now, we can't exempt rules because obviously you are accessing all these big databases, so you would be a weak link. So, Mr. Garcia, how do you balance this? you got her having to match, overlapping, Mr. Weissman saying we need to allow states to have a particular role, Mr. Quashi saying, no, we need to have a single standard, and Ms. Stevenson having to live under that conflict. How do you address that?
You know, I'm sorry, repeat the question. I was,
So we've got a conflict here. Do we allow states to come up with their own privacy laws? Or, as Mr. Quashi says, do we preempt to have a single standard, recognizing that maybe there's something peculiar to sensibility in a particular state, but Ms. Stevenson is telling how she's having to live under overlapping and at the
yeah, and I
expense.
think, yes, sir, I think that has been a long-standing issue, that having too many privacy laws and reporting laws to comply with is very expensive and inefficient, and if we could centralize.
But you're not saying do away with HIPAA. I think you would agree
No.
with enforcing, strengthening HIPAA.
We're looking at, I look at HIPAA in terms of the security rule, and that's the most important thing, and we need a security rule in HIPAA that is modernized according to today's standards.
According to what standards?
Today's standards in terms of the cyber threats that we are facing, in terms of the widely distributed digital infrastructure that is supporting healthcare. We need to have a HIPAA security rule.
So is there anyone here that would object, for those who spoke about cybersecurity, is there anyone here who would object to having HIPAA begin to cover the medical information which is sent out by wearables?
No objections.
Yeah, I think we would have an objection because HIPAA is a healthcare law for healthcare stakeholders.
But Mr. Quashi, if I've got a watch which looks at my kind of gait and how often I fall, and then I'm falling regularly, that could indicate that I've got a medical condition which could cause some sort of underwriting under any person. Would you agree with that or disagree?
I would agree with that, but we would suggest that a new federal privacy law that covers non-HIPAA covered entities, among others, with some specific health provisions is the way to go. Because a lot of these non-covered entities under HIPAA have both services and tools that have healthcare and non-healthcare uses. A lot of these companies are not healthcare companies.
Yeah, but nonetheless, if they have the data they're accumulating is healthcare data.
It is healthcare data, but it should be covered under a new law which reflects current healthcare and data use realities.
So would it have less teeth and less?
No, we actually would say more teeth, better enforcement, and better guidance for stakeholders that can follow one set of standards. We want state laws preempted because currently we have, as I said in my opening, we have 20 state laws. It's very expensive and cumbersome to try to comply with varying standards. I think one standard would be perfect.
Sounds great. Senator Hassan.
Well, thank you, Chair Cassidy and Ranking Member Sanders. I want to thank the witnesses, not only for being here today, but for the work that you do. And while today's hearing topic of cybersecurity is indeed an important one, and I do have a couple of questions about it, I want to start by acknowledging the larger threat to our hospitals and the health of our constituents today, which is the threat of the $1 trillion in healthcare cuts that President Trump signed into law last week. And with respect for the chair, I do want to say that there are provisions in the bill that was signed that will impact nursing homes, including the retroactive coverage provision. Many of our rural hospitals are also going to be impacted in significant ways. They already operate on thin margins, and these cuts to Medicaid and the Affordable Care Act will force many rural providers to the brink of closure. So I want to start with a question to you, Ms. Stevenson. In your testimony, you talk about how the rural health system that you work for serves many patients covered by Medicare and Medicaid. Nearly 80% of your patients are covered by public insurance. You also discuss in your testimony the financial constraints that rural hospitals are operating under. Ohio is set to lose tens of billions of dollars in Medicaid funding over the next decade because of the Republican budget bill that President Trump signed into law, with more than 400,000 people in your state losing their coverage. What challenges will your hospital face as a result of these coverage losses?
Thank you for that question. Challenges that we would face if that is the way it comes to bear would be reduction in staffing, reduction in budgets, which we're already looking at to see where we can consolidate, probably closure of services that are not as profitable, but sometimes we've had a tendency to stay longitudinal in our care and try to provide everything from birth to death. But we'd have to look closely at all of those.
Thank you. Now, Mr. Garcia, as you know, last year there was a ransomware attack on Change Healthcare that exposed the personal data of more than half of all Americans. Many Americans didn't receive a notification from United Healthcare until more than a year after the hack, meaning that their data had been exposed and potentially available on the dark web for a full year before they were notified. Mr. Garcia, how can we improve the healthcare system's accountability to patients when breaches like this happen?
Yeah, thanks for that question, Senator. I can't explain that long delay. What we've done in the Sector Coordinating Council is to try to map the entire healthcare sector and find out where are those other critical services and utilities like Change Healthcare that
Right.
could be choke points
Yep.
that if severely disrupted could impact the entire sector. So we are mapping that out now. And this goes back to a lot of the third-party service providers, technology providers that the chairman was referring to. How do we identify the risk like that kind of service and then manage against that risk? So that
Excellent.
we don't have loss of patient care and liquidity.
Well, and I think Senator Cassidy has already mentioned it, but he and I introduced a bill last year to improve minimum standards for health cybersecurity and for breach reporting. I look forward to continuing to work on that on Congress, and I assume that that might be a good step forward as well.
Absolutely. We'd like to work with you on that.
Thank you. Ms. Stevenson, I have a question related to your role overseeing the cybersecurity for a rural community health system. Following the Change Healthcare hack, I worked with 3 of our small rural hospitals in New Hampshire to get them resources from United Healthcare and the federal government so that they could stay open. Even with this short-term assistance, the recovery from the hack is still ongoing. For example, one New Hampshire hospital is still working to catch up on last year's backlog of claims and reporting requirements. How can the federal government help rural hospitals address the long-term impacts of cyber attacks?
That's a great question, and one I've given a lot of thought about. I think a couple of things. One, leniency in areas of required breach reporting. So if we are all part of a breach, our focus is not the breach reporting, our focus is recovery.
Right.
So giving us some leniency there. Extension of claim processing deadlines, so we don't, there's a limitation on claim processing, 30 days, 60 days. We may not make those.
Yeah.
Thus, direct financial loss. Assistance with any advance payments in anticipation of a slowdown in cash flow.
Right.
Whether that's loans, et cetera. Support with emergency services that we might need to respond and recover. Sometimes we don't have the technical expertise in-house.
Right.
That would be another opportunity. And then remove liability concerns. This is what we're all talking about here is we need to be able to talk to each other, to connect to each other and disconnect to each other with good conversation. But we're all afraid to talk about it. And if we have that opportunity and less liability, that would be very helpful.
Yeah. And I will just say very quickly, on the Change Healthcare hack, one of the things that really just blew my mind, frankly, was the loan terms that Change and United Healthcare tried to impose on the rural hospitals who had been impacted by their breach. I mean, they were just completely unfair loan terms. We worked it out with them and we pushed them to just give the loans that the hospitals needed to have their cash flow protected. But that's one of the things we need to look at too. Thank you, Mr. Chair.
Thank you, Senator Hessen. And Senator Hawley.
Thank you, Mr. Chairman. Thanks to the witnesses for being here. Mr. Garcia, if I could just start with you, I want to talk a little bit about the challenges that rural hospitals in particular face from cyber attacks, malicious actors. What do you think, thinking about the Volt Typhoon attack of this last year and a half, what do you think are the most important lessons that we ought to draw from that attack, and particularly if you could apply this to rural hospitals and the challenges that they face?
Well, thank you, Senator. Certainly there are very sophisticated attacks out there from nation states and other sophisticated criminal groups that are beyond the capacity of rural, small, critical access health systems to counter, even the larger health systems. We cannot beat nation states. We did a publication in May called On the Edge. We interviewed 40 executives across 30 states, not just rural, but critical access, FQHC, small practices, asking them, what are your concerns about cybersecurity? How are you prepared to deal with it? And what would you need from the government or from your community to support you on that? And the results were not surprising. They said, we know what to do. We don't have, as Ms. Stevenson said, we don't have the capacity in workforce to deal with this. We don't necessarily need training. We need people. Bring the people in, and we need some support, whether it's financial incentives to invest in better cybersecurity or direct financial support. So there's a lot of, I commend the report to you. There's a lot of recommendations in there for both us in the industry and for the government.
Ms. Stevenson, do you want to add anything to this?
I think that was a great summary. Thank you.
More than 40% of the hospitals in Missouri, my state, are rural hospitals, and about half of those are critical access hospitals. And I just want to underscore something you said, Mr. Garcia, that many of these hospitals have faced some level of cyber attack, and they simply don't have the personnel or the budget to deal with it. They don't have a cybersecurity officer on staff. They don't have the budget to work on turning back cyber attacks. What should Congress be doing to help rural hospitals in particular be able to meet the challenge of malicious cyber actors and the threats that this poses to patients, that it poses to hospital staff, that it poses to the working of the hospital? I mean, what can we be doing to help rural hospitals? I'll start with you, Mr. Garcia, and then anybody on the panel who wants to respond is welcome to.
Well, certainly, we've talked about better incentives. When you think about CMS, can they tie some level of reimbursement to better cybersecurity practices? You're doing the right thing. You're implementing the health industry cyber practices that we produced, or the NIST framework. We're going to give you a little bit of a bump on your reimbursement. That's real money. Senator Husted talked about National Guards at the state level, those who can help in what we call a 911 cyber civil defense. How can we rally the community around your rural hospitals who do have the expertise? It's a lower cost option, but where the government can be using its reimbursement authority as leverage, that can be helpful.
Very good. Anybody else want to add to this? Yes, sir, Mr. Weissman.
Well, 2 points. One, unfortunately, I'm afraid that the reconciliation costing rural hospitals Medicaid funding is going to make some of these challenges harder. But two, I wanted, in building on work that you've done, and Mr. Garcia talked about Change Healthcare as a utility, because we have so much concentration in the industry. It is true that rural hospitals are just overwhelmed, but the large companies are not, and they are not investing enough. And there is, I think, a need to impose extra obligations on them, new standards, and absolutely to maintain their liability. I disagree with the suggestions to remove liability. The way they're going to be held accountable if we don't have adequate regulatory standards is through lawsuits that make them pay retrospectively. Better if we could stop it in the first place.
I've introduced a bipartisan bill called the Rural Hospital Cybersecurity Enhancement Act. It does some of the things that you were just talking about, Mr. Garcia. It starts at just a very baseline level, directing HHS to develop a comprehensive cybersecurity strategy for rural hospitals, to look at workforce needs, to look at funding needs. I think this is long past due, and again, I can just tell you, coming from a state where 40% of our hospitals are rural. I grew up in a rural area. I live in a rural area now, grew up in a rural area. Those hospitals are often the lifeblood of those communities, and they literally save people's lives. And we've got to do more than we are doing now to protect those hospitals, number one, in all of their operations, but also, number two, in helping them from this cybersecurity threat, because they're simply not equipped to deal with it. And realistically, they're not going to be, absent some assistance from the federal government. They do not have the wherewithal on their own. So we've got to do more. I hope that we'll be able to mark up this bill soon in this committee and take it to the floor as a place to start. Thank you all for your testimony, and thank you, Mr. Chairman.
Thank you, Senator Hawley. Senator Hickenlooper.
Thank you, Mr. Chair. Thank all of you for being here and for your work on this very difficult issue. Let me start with Ms. Stevenson. In March 2025, the Department of Health and Human Services proposed modifications to the HIPAA security rule to enhance cybersecurity protections. Certainly the lack of standardized secure data sharing protocols in the healthcare industry increase our vulnerability to cyber. Obviously, encryption is currently not explicitly mandated under HIPAA. In Colorado, we have a national, what was named the National Cybersecurity Center, which fills in a lot of these gaps at the state level and specifically provides training, both programs that impact assessments, other resources, to rural hospitals throughout, not just Colorado, but in the region, because often that training has to happen in person. to make a difference. How can we support the development of federal data sharing standards that build upon successful state-led efforts like what we have at the National Cybersecurity Center in Colorado Springs?
Thank you, Senator. I believe that what you're doing is good in terms of offering those local resources for training. The more educated everybody is, the better we can operate as a supply chain, a healthcare supply chain. It is a challenge, and the new HIPAA security rules that were proposed, while I do agree that standardization will be very helpful, encryption helpful, there were some things in there that were burdensome in terms of asset inventories and work that would be well beyond what we are able to do, especially in rural healthcare. So while I do agree we should go forward in that direction, I think that there's some modifications we could do.
Well, I agree with you there as well. I think certainly the cuts we're going to see to the rural healthcare system because of the cuts to Medicaid are going to be significant, and at a time when we should be providing more resources, less resources is going to be a problem. Mr. Quashi, wearable technology, and this is a little bit of an offline, but I think it's real. This wearable technology has become ubiquitous. People have smart watches that they wear, fitness trackers, collect all kinds of sensitive personal data, you know, heart rate to blood oxygen, whether it's a ring or a wristwatch, whatever. But unless that data is being shared with a healthcare provider, the standard HIPAA security rule does not, what ordinarily would provide cybersecurity guidance for health records doesn't apply. It's true even for data collected, but that is very sensitive and very personal. Some states have enacted laws, such as the Colorado Privacy Act, that requires companies that collect such data to implement specific cybersecurity safeguards. Mr. Quashi, how can we address the cybersecurity gap that still exists for wearable devices not covered by the HIPAA security rule?
Thank you very much for the question, Senator. And I talked about this earlier in my opening statement. I think, and it's the position of my association, that we need a new comprehensive federal privacy law that covers, among others, those institutions and organizations that are not covered under HIPAA, right? And a couple of things to mention there is that for us, preempting existing state laws is going to be very key. So we have one standard that consumers and other stakeholders can adhere to. And number two, no private right of action. We believe that any new federal law should have strong enforcement teeth with a designated federal agency that will be the primary enforcer of the new law. Again, we can have state officers supplement and help enforce the federal law. And that, to us, will go a long way in solving some of this problem. But I think we need a new way to think about it. Unfortunately, given the digital economy we're in, state-centric solutions to this problem are going to be increasingly unfeasible. Data knows no borders. Data can travel across a border in a nanosecond. So I think we need to rethink how we approach some of these data-driven regulatory frameworks.
We agree with that. The states are the laboratories of democracy, but we need to be willing to go forward and take the lessons we're learning in the states and put them to a national level. Mr. Weissman, I'm going to try and look at my electronic watch, try and squeeze this in. And you talked a little bit about how we can help get resources for local hospitals to be better prepared and more resilient around cybersecurity attacks. How else can we support rural hospitals in this battle they're engaging? Because they are the undefended.
Well, when we broader institutionally, I think there are a lot of proposals that have been floated here that are important. At the end of the day, it's going to be money. It's going to be money and resources that is going to have to come from the federal government. The reconciliation bill goes in the opposite direction. In the area of cybersecurity, to some extent, it's the same thing, as we've heard compellingly. But I do think it also makes sense to think about the chains of responsibility. The problem with cybersecurity at rural hospitals is not just their own local thing. When Change Healthcare happened, that breach, that was a problem for every rural hospital. And what's the responsibility of United Health Group back to those rural hospitals? What should they have done in the first place to be more preventative? What should they have invested? They do have the resources, unlike the rural hospitals. And I think we need to be thinking much more about these top of the food chain players as well.
Thank you. I yield back to the chair.
Thank you. That ends our hearing. I thank the witnesses for being here. For any senator wishing to ask additional questions, questions for the record will be due at 5 p.m. Wednesday, July 23rd. Thanks for being here.
Mr. Chairman, I'd ask unanimous consent.
Committee stands
Get this
adjourned.
updated to the record. No? That's very nice.
Thank you.